IVF in those days was nothing like it is today.
Very
We
different.
used Clomid, and the first pregnancy that we had that was a live birth, I gave her 5 days of Clomid and got 2 eggs from her.
Wow.
This was a young woman, both fertilized, and we transferred both when they were 4-cell stage.
I want to set the stage for the conversation by taking us back to 1980 or 81. I was 10 years old, and I was sitting at the kitchen table eating a bowl of boxed cereal and looking at an infographic in the Indianapolis Star newspaper. It was just like 4 by 6 inches, and it showed grab the egg from the woman and the sperm from the man, put it into a long glass test tube, and then
That's why they were called test tube babies.
Test tube babies. Exactly. And I was like, this is fascinating. I couldn't believe it. I just was transfixed by the image and the idea that we were doing this. And I think I was always just kind of like one of those odd kids that was in my own like daydream world. But I think I thought I saw that and started thinking futuristically. So
that would have been probably 1982 when we announced our first successful pregnancy from IVF when I was at USC. You were 10. I was a little older than you at that time. So now you know where I am today. But the first IVF we did was in 1981, the September of 1981. And we were very fortunate that the 5th IVF transfer cycle in that first series produced our first delivery in June of 1982. That was the very early days.
yeah.
And the days where we knew nothing,
Right.
literally. So pioneer is kind of a funny word, but everybody talks about pioneering. There were just a bunch of doctors that figured out how to do the basic steps, and then we all learned from each other, building on one person's knowledge and the next step, and the next step. Because really there was not a recipe or any kind of directions of how to do IVF other than what Edwards and Steptoe did in 1979. So it was a learning process.
So that 1979 looked like what?
Well, Edwards and Steptoe had worked for a couple of years with human IVF before they had a successful pregnancy and delivery in 1979. And then they were the only center in the world.
Mm-hmm.
2 centers in Australia, in Melbourne, Australia, set up IVF centers in, I think it was 1980. They started doing IVF. And they both had a successful pregnancy in 1980 and 81. Before I started at USC, I traveled down with Joyce Vargas, and we went down and visited the Melbourne centers, and I worked in their labs and everything for 6 weeks, trying to I made a nuisance out of myself, and because I was asking questions, but when I came back in August, I started IVF at USC. I'd already gotten approval by our institutional review board, so we went to work, and we were very lucky to have a pregnancy with the 5th transfer.
So you and Joyce were researchers who were gynecologists too? You had an obstetric?
Joyce had done her obstetrics and gynecology residency, and she was actually starting a practice in OBGYN when we got married. And she traveled down with me because she was pregnant with Ashley, our daughter. Mm-hmm. And so she wasn't feeling great. And so, but that was necessary for me to come back and get going. She went on and did a fellowship at USC, got her reproductive endocrine, and then she joined the IVF team after that. Okay.
So I recall IVF started out because there were tubal issues and...
Oh, there were horrific pelvic factor problems. In the 70s, a particular IUD that was used, it looked like a little crawfish type thing. And it wasn't the problem with the plastic IUD. It kind of filled the uterine cavity, but it had the string on it, but the string was a multi-fibered string. And they didn't realize at the time that when they started using the IUDs, that women would get an infection because bacteria from the vaginal canal would wick up in through that multi-fiber string, get inside the uterine cavity. Gonorrhea rates in those days were huge. There were all kinds of infectious disease, pelvic inflammatory disease. But once the uterus got infected, it went into the fallopian tubes and destroyed literally the fallopian tubes. When I was a resident in Texas, we saw patient after patient after patients that came in with septic from tubal infections and all kinds of, and they were losing their reproductive tract organs. So that was what started when, even if they were cured by antibiotics or surgery, they had no tubal function. And that's why we decided, well, Edwards and Steptoe said, we've got to be able to bypass the fallopian tube. IVF just bypasses what goes on in the fallopian tube. So when we talk about an IVF lab, it's an artificial fallopian tube. It took us years to be able to figure out what that artificial environment needed to be to grow embryos in the lab. And today it's highly successful. The tubal environment, I think probably if we could get inside the tube today and check what our environment is with the intertubal environment, which we can't, but if we could, I think it would look very similar. So IVF had to happen because these women were hopelessly infertile.
Yeah, right. The way that you have seen that to where we are now with 4 million babies born through in vitro, I cannot even imagine what it's like to be you, to have watched all of that. But I do know the curious mind and the questions and the way that this particular science can grab somebody who's got that kind of instilled in them, that inquisitive nature, a visionary spirit, and a desire to help. So you are there, you're following this this guy in the lab down in Mexico, and you're watching and looking at what he's doing, and you're thinking, okay, and then you come back to USC, and were there, you said IRB approved the study. So how many women were you working with? That, like, how did that get decided?
That's a funny story too. Everybody had heard about IVF because of the Australian two births in Australia, the English birth starting it all out. There was one center in the United States at Eastern Virginia Medical School. Howard Jones had retired. He was a professor at Johns Hopkins University. He retired because they had to retire at age 65. And he had been interested in IVF. He was an OBGYN, but he did infertility. In those days, he didn't have fellowships or anything else. But he was a highly respected infertility specialist. He and his wife, Georgiana Seeger Jones. They decided that they wanted to do IVF, so he went to Eastern Virginia. They allowed him to become part of the Eastern Virginia Medical School faculty, and he set up an IVF program in Eastern Virginia Medical School. And he brought a team of people. He went over to England and watched Steptoe and Edwards. They came back, and they had a team of like 20 people, embryologists and all kinds of things. And they started doing IVF in early 1980. And they were doing IVF and had no success. They had a lot of, believe it or not, resistance. They announced they're doing IVF, and then, they had a lot of anti-IVF type, that people in the South didn't think it was right. It was not religiously acceptable. It was
playing God.
Yeah, it was out of the human body, so we don't believe it. So he actually had protests outside of the medical school. They announced their first pregnancy in early 1981, and they had done about 200 cycles of IVF when they had their first pregnancy. When they announced that pregnancy, they were just inundated with right to life protests and all kinds of things, and they got through it. We announced our pregnancy in late 81. Their first baby delivered in early 82. Then they got, again, overwhelmed with, anti-abortion type stuff in the Southeast. I saw all of that. We were worried about it when we announced our pregnancy. So before the Right to Life, the chairman of the Right to Life movement, or whatever they call it, Right to Life Committee, they were all over the United States in the early 80s. I said, we got to talk to this. So I called him, told him who I was, told him what we were doing, and told him the mechanism of what we did and that we were creating life. And it was not very successful, but we do have a pregnancy, and Howard Jones has a baby already delivered. And I said, you got to look at this not as a life-taking, but a life-giving process. This guy said, you're absolutely right. We never had a single comment in the newspaper or anything else when our announcement came out, and it was just sailing. But Howard had problems. It was just a different part of the country. So, and today you're seeing that same thing. 40 plus years later, we're going backwards in time with this craziness that's going on with, embryos not being able to be, or having personhood, not being able to discard an abnormal embryo. The whole Alabama thing was a nightmare and a disaster. But fortunately, the Alabama legislature got that taken off. But it's still out there, which is just, people need to be educated that this is not a life-taking process at all.
Right. Quite the contrary, especially as we're seeing, for different reasons now, another slump in fertility, right, in the population, and a need for in vitro is definitely there. I have this book that came out in 2016 called The End of Sex and the Future of Human Reproduction. Do you know this book?
Yeah.
Okay, so it's not a science fiction book, but it came out in 2016, and then it left the Amazon. I couldn't find it anywhere. But it's talking about the idea of going back, I think, to ZIFT, zygote intrafallopian transfer. And he proposes that the combination of ZIFT and genetic screening and a shift in insurance will make in vitro safe, effective, and free, and the way that we keep the species alive.
Well, we started GIFT,
which is the gamete
intrafallopian transfer, because IVF was so low success. I mean, the first series that I published from USC, we had a 12% live birth rate from a transfer procedure, IVF transfer procedure. In those days, IVF in those days was nothing like it is today.
Right, very
We
different.
used Clomid. And the first baby of our first pregnancy that we had that was a live birth, I gave her 5 days of Clomid and got 2 eggs from, this was a young woman, but Clomid for 5 days, got 2 eggs, both fertilized, and we transferred both when they were 4-cell stage, because we didn't know how to grow embryos beyond the second stage of embryonic development.
And there was no need to shoot for 15 eggs at the time.
Well, we couldn't get 15 with Clomid.
Right.
Now, so the first couple of years of IVF, I spent most of my time developing the stimulation protocols that we use today, because we realized that these, by definition, our Institutional Review Board, we could not treat women over the age of 34. The Institutional Review Board told me that women would not get pregnant at age 35 and above. I said, well, I don't think that's true, but you're deciding my fate as far as what I can do. So they had to be ovulating women, and they had to be, their partners had to have normal sperm counts, and we were limited in that group. But these were young women that, today a 34-year-old woman with a standard stimulation will probably give you 12 to 15 oocytes. But with Clomid, you get 2 or 3, even in a 34-year-old or younger. So those limitations were there. But as we got more knowledgeable, and as the IRB allowed us to expand, before we got out of under the IRB control, they allowed us to go up to 39. I finally convinced them that women over 34 could get pregnant. And so they extended at 39, but wouldn't do it 40 or above. So those are all the things we had to deal with, step by step by step. But, when we started stimulating more, we got more eggs. But when we got just a couple eggs, and IVF was 10% likelihood of pregnancy. Ricardo Ash, who ended up not having such a good reputation, but he was the one who developed the gamete interfallopian transfer procedure. He was at University of Texas in San Antonio Medical School. He developed GIFT. So we started doing GIFT. And we found that because they were normal patients and normal sperm, normal eggs, young women, we found that the pregnancy rate was double what it was with IVF because our laboratory wasn't supporting embryonic development. But the fallopian tube in those women with unexplained infertility did. They may not work and pick up the eggs. That's why they weren't getting pregnant, because of tubal function. But once the egg and sperm were in the tube,
they found each other, made their own zygote.
And we did GIFT. And then as we started doing patients that had a poor sperm profile, that's when we went to ZIFT, zygote interfallopian transfer, because we needed to see if the egg would fertilize before we put it back into the tubal environment, expecting a higher pregnancy rate than fertilizing and putting the embryo back in the uterus. And so ZIFT and GIFT were used for, we stopped doing those in 1992. We personally stopped because our IVF pregnancy rate at that point started equaling ZIFT and GIFT. And so when that happened, we didn't have to put the women through laparoscopic procedures.
To insert.
So step by step by step, we tried to look at the data, make decisions, and improve what the patient care profile became, because I always felt that it needed to be less and less invasive. Mm-hmm. And that's where we are today.
Mm-hmm. Yeah. Could you talk a little bit about your developing the stimulation protocols? Because Follistim, Gonal-F, Menopur, those are the big ones. I do remember some Pergonal cycles, so you're laughing.
So do those patients that used Pergonal for a long time.
Okay.
So the progression was that Howard Jones used the Edwards and Steptoe stimulation protocol. And Edwards and Steptoe used Pergonal. Pergonal was developed by a scientist in Europe. He developed human menopausal gonadotropins. He was an endocrinologist and realized, and they used pituitary FSH and LH to make the first gonadotropin stimulation, the injection. So Edwards and Steptoe used Pergonal, as it was named, and it was a mixture of FSH and LH that was extracted from postmenopausal women's urine. So, believe it or not, the European company that was making Pergonal had women collect urine. Mm-hmm. And they took the safest population that they could find. They took nuns, Catholic nuns, to collect their urine. And they paid them for collecting their urine, the postmenopausal nuns. And that's where they made their Pergonal. They extracted the FSH and LH from the urine and purified it, and the women injected it. That was the next step to Clomid. So Clomid, when women took 5 days of Clomid, sometimes even the young women would get 1 or 2 or at best 3 eggs that would fertilize. They may get some immature eggs, but usually not many. So the first step that I looked at Howard Jones's stimulation, all the eggs they were getting versus what we were getting with Clomid, and the Australians were using Clomid also. And I said, well, wait a minute, Howard, we're getting on average 2.5 eggs per IVF cycle, but Howard Jones is getting 8 or 9, between 8 and 9 eggs. Now, when you looked at their fertilization rate, it was almost the same as ours, which is about three fertilized eggs per IVF cycle. We were getting 2.5. And I said, well, why is that happening? Well, what was happening was that using a low-dose Pergonal, they got a lot of secondary follicles that they could get an egg from, but they weren't mature. And so I said, okay, well, let's put them together. So that's when I developed the Clomid Pergonal combined stimulation, because I felt like the Clomid was giving us good quality eggs, but just not enough of them. When we added Pergonal, beginning on the 5th day of the Clomid, overlapping the 4th and 5th day of Clomid, adding a small amount of Pergonal, we did get more eggs. Mm-hmm. But unlike Howard Jones, we were getting more mature eggs and more fertilized embryos.
Why is that?
He was only getting about 3 mature eggs because if using just 150 units of Pergonal didn't get those, all the follicles weren't all growing together.
The synchronizing?
So they were not synchronized. the Clomid overlap got synchrony of more of the follicles, and then the secondary follicles still were there from the Pergonal effect because you used 5 days of Clomid. The last 2 days overlap with Pergonal, day 4 and day 5 of Clomid, Pergonal, those, and then Pergonal every day after that. We boosted our mature rate and got more fertilized eggs. And Howard's going, because I presented that data one of the world conferences, and the first time I showed the differences between stimulation. I used Pergonal alone as a third arm of the study and showed again we got as many eggs as the Clomid overlap, Pergonal, but they weren't mature. The fertilization was just like Howard's was. So that was the first step in change. And then we kept looking at different types of profiles. I won't go into, they're boring because we did a lot of studies, parallel trials in our own patients to see what worked before we changed to something. But today, Pergonal was a good drug, but it was not pure. And the reason I said, if you ask women who took Pergonal, they remember it because we actually, when they were beginning to make Follistim, what's called Follistim and going left today, which is a recombinant DNA produced FSH and LH. So it's not a human product extracted like Pergonal was. Don't want to get too technical, but Pergonal was just what was in the postmenopausal woman's urine, and the chemist pulled out the FSH and LH, but it had a lot of other proteins in it from that urinary substrate. They couldn't purify it. Women had all kinds of reactions. Some women would get high fevers from Pergonal injections. Some women just felt miserable from it. Those proteins that weren't active for follicle stimulation were creating a lot of side effects to these women. And I used to joke in those days when a woman was on our Pergonal arm by itself or the Clomid Pergonal, I'd kid them when I'd open the door to go do the ultrasound. I'd wave white hands. I said, is it safe to come in?
Oh,
because some of them just were like, attacked me. And I'm feeling so terrible today. I've got 102 fever. And, and they did.
Yeah, which isn't really ideal for the transfer
no, it was
a few
terrible.
days later.
It was terrible. Not all of them had it, but some of them reacted. I finally had a biochemist that came into my laboratory because Sirona was the one developing the recombinant FSH for the new stimulation. I had a PhD come in and actually do a profile of all the proteins in Pergonal. And he went through and showed what the proteins were and what the FSH activity was and LH activity in postmenopausal women. And that's how, when they started developing the recombinant, they looked at some of that data and said, oh, well, we want these proteins. These are the FSH activity levels we want. And I remember going to Boston and meeting with them once before they were making the final decision of how many isoforms of FSH they were going to put in the recombinant FSH. And we argued about it. I said, well, this isoform is more bioactive than that. And they said, yes, but it has a shorter half-life, so we can't use it. It's not a long enough half-life. I said, but he said, no. So I'm not a biochemist. But anyway, that's how Follistim and going left came about. The reason there's two of them is because Organon was developing a recombinant FSH at the same time as Sirona was, and they all claimed that they got their product at the same time and had the product approval and with the FDA, and they got in a big lawsuit and they finally said, okay, we're not going to fight this out. We'll do one is going to be called Follistim, and the chemical mirror of that FSH profile is Gonalef. So that's how they both came on the market. Oh my God. But recombinant FSH was a huge boon. And then we started stimulation studies all over again because the recombinant FSH was totally different.
Game-changing.
And so then we went through studies with different formats of using those. And again, there's nothing pioneering about what I did or any of the other people. We just followed the steps. And with any kind of science, yes, you need knowledge, but you also need experience of what's worked, what didn't work in the past, and then you decide that experience is real and make your next change based on what you've learned. And you have to have some common sense. Medicine is just not all numbers and science. You got to have some common sense. Yeah, but like for that instance when I was talking to the biochemist about the FSH isoform, they were saying, yes, it is more potent, but it won't stay in the system long enough. So I go, oh, okay. That makes sense.
Well, I think more than common sense, it's a sense of intuition, and that intuition will keep messing with you and right, like knocking and saying, it would say like, Richard, take it to the next level. Take it to the next. It would just keep nudging you to push it along. That's how.
It was absolutely true. I'd wake up in the middle of the night and go,
I have
wait,
to.
that makes sense.
Right. Because in the middle of the night.
I'm from Texas. I call it common sense.
Right. But
you're
here
right.
in LA.
I think it is, because you have to let it mull in your brain for a while and then come back to it. And then you have to have a sense of what you think is right. So.
Right. Well, having only done a small pilot study myself with the SEED program as a IVF intervention, I didn't do that right when I first started using the SEED program and helping women through it. I did that in 2018 after years of watching how it would come out so that I could get a sense of how I wanted to design the study in the first place. So those kinds of intuitive hunches and the combination of experience and you also are known in the field. So your voice and your experience and the outcomes and the numbers and the data, those have to be there too. So, it wasn't like you just said, hey, I've got this cool idea, or hey, I thought of this at 3 a.m. It was everything combined.
Well, I can tell you a story about that too.
Tell us, because I think that when we hear these stories and we gain an understanding of what happened, then there will be an appreciation, at least on the part of the listeners, when they're going through these protocols and these procedures. And if it doesn't work, instead of so quickly comparing to their friends who are getting all these other eggs, or these people who are conceiving natural, there's more of an appreciation for what you're providing from a scientific standpoint, because IVF has become so commonplace now, it's almost taken for granted. So a big value of your conversation here is that appreciation, the landscape, and the background.
Going back to the early days of IVF, as I said, there was Edwards and Steptoe in England. Alex Lapata was the lab director in one of the Melbourne centers, and there were two centers, Queen Victoria and the other hospital. They were competing, and they were fighting with each other in Melbourne when I was down there. And I went down there. I said, look, I appreciate the invitation. The Melbourne hospital gave me the first invitation. They put us up in their guest apartment because I didn't have any money. So we lived in the guest apartment. But I went from their program across the town to the other. I said, I want to visit both. So you guys are going to have to tolerate me. And they said, oh, they're not doing these things right over there. And I said, okay, I need to see the wrong way and the right way then. But anyway, I went back and forth. And over the 6 weeks, I got to know them, they got to know me, and I started talking about, I said, look, I'm going to talk to the other guys, about what's going on in this lab because they're doing it different. By the end of the 6 weeks, they started talking to each other and had a combined meeting before I came back to LA, because they finally realized, hey, they can learn from each other, because I was going around messing up with their minds about, really, you didn't think about doing it this way? And so that's when they started putting their stuff together, all of their data together in Melbourne. And they really did do a lot of good work. Mm-hmm. Most of the early development beyond that came out of those Melbourne groups, and they were working with each other and sharing it. You have to understand, in 1980, 1981, there was no internet.
Right.
There was no any way to communicate. Mm-hmm. We had fax machines, but not everybody had a fax machine. Mm-hmm. So we relied on, a long distance telephone call. We didn't have cell phones. Mm-hmm. So to get information, the way we did it, the 5 centers, Howard Jones and his group didn't participate as much as I did. But I when we had a meeting, and a joint meeting for IVF, and they had several of them around the world, we all had to present our data. And then after the formal meeting, the 4 groups, the 2 Melbourne groups, Howard Edwards, Bob Edwards, and myself, we would start working together. And we'd start, at 6, 7, 8 o'clock in the evening and go through till 2, 3 o'clock in the morning, whatever. We needed to know what was going on, and we put things together. And then we came back the next meeting and updated everybody. By the time we published all this, and it was published, but it came out 6, 8, 10, 12 months later in the journals.
Mm-hmm.
So we were interacting in between when we got together in meetings. And you know, we didn't have a computer to do the data. I had a little hand calculator when trying to do
composition
statistics.
notebook.
Yeah, it was crazy.
Science.
But people don't understand that all this, electronic systems we have today, there was no such thing back then.
Right.
So people talked to each other,
Mm-hmm.
and it really was beneficial.
Mm-hmm. Yeah. Well, it was a community, and it was needed like that at the time. That was how it got done. So I really appreciate you going back in time and sharing that story. It's great.
Well, it was, looking back on it, it's probably the best time I've ever had in my career. Just learning together.
Right. The friendships and
Right.
not knowing, and also not having the responsibility on you that followed. Like Ashley mentioned that she was just a few weeks old, and there she is in Joyce's arms on CNN.
Right.
Joyce sticking the bottle in her nose because she's so nervous with the whole thing.
Right.
Like I just can't even imagine how everything changed. And then suddenly you're here in the US, and it's like, can we do that again? Can we recreate it? Can we keep going with it? And did you have a sense of this is never going to work? There's no longevity. This is too much work. It's too hard. Or did you think?
But I was told
oh,
by
of
the
course.
chairman of the department when I finished my fellowship, I'd already started to develop the IVF model. I went to City of Hope to learn how to do. Dr. Oscar Kletsky was one of my professors at USC, and I was doing a lot of work with him on endocrine development. We didn't even have assays for most of the hormones we measure today, and he was trying to build assay systems to measure estrogen and prolactin and TSH, the hormones we do all the time now. There were no assay systems to measure those in the human. And so he had me developing those. We were dealing with pituitary tumors in young women that were prolactin secreting. We had no idea what these were, but the neurosurgeons thought they were precancerous. They were adenomas. They were doing neurosurgery on them. So, and Oscar was just crazy about the fact that they were doing brain surgery on these benign tumors. So he said, we've got to show them that this is, and so we set up a protocol to use pituitary adenomas in an in vitro culture environment. There were no medicines like bromocriptine or anything else that we use today for oral, just to reduce an adenoma medicine. Nobody's had surgery for decades. But he said, there's got to be something. These are adenoma cells. They're not cancer. And so he had me taking pituitaries out of mice, and then we'd put them in culture, see if we could grow the cells and give them certain stimuli to secrete hormones. He said, okay, we can do this. He said, now we got to talk to the neurosurgeons. And he got a couple of neurosurgeons that were doing these adenoma removals and these benign pituitary adenomas. And they were giving me the tissue, and I learned how. I went to City of Hope and went to their cytotech laboratory where they were growing cancer cells, because City of Hope was doing a lot of research, still does. But they would plate out these cancer cells and grow them in to keep the cells alive and do whatever they're doing back then for cancer treatment. So I went out and learned how to do it. We did the benign adenomas, grew them, and then we started seeing what would inhibit the prolactin hormone. And that's where we found bromocriptine would be an inhibitor of prolactin, and it actually killed off the cells. And that was presented to the Society of Gynecologic Investigation. And it was very important. But I was saying, but I want to grow embryos because that's my big, and that's why I did that. So when I went to Australia, I already had knew how to do cell cultures, and they were going, where'd you learn how to do that? And I said, it's a long story, but I had done it for that reason.
All of the steps are interconnected.
Yeah.
I mean, when we're in it, and it's the same is true for fertility, right? When the patient is going through it and it's failed attempt after failed attempt or a loss after loss, and they can't see the end happening in the way that they wanted, or they don't see the outcome because they're too much in the mess. I like to remind them that there is a time where they'll be through this and they can look back and see that the points were actually connected. But right now it feels like being in a bowl of spaghetti. So any kind of research, any kind of process that needs time to unfold and have connection points and conversations and shifts made looks harrowing in the moment.
Yeah. And, the one thing that we kind of recognized, not at the beginning, but by the early to mid 90s, we started really listening to the patients. And instead of me being so terrified about what the next step was going to be and was going to work, and I was worried about side effects, and we started listening to the patients about their comfort. I mean, the Pergonal thing was horrible, but when we got the recombinant FSH and got rid of Pergonal, but it was much better. Side effects from stimulation meds were just gone. And then Menopur was developed. Menopur is just a highly purified Pergonal. Mm-hmm. They took all of the bad stuff out of Pergonal in Menopur. Menopur is a human FSH and basically HCG. It's not really LH. Postmenopausal pituitaries put out HCG. Some LH, but mainly the HCG, and the HCG is a much more active protein. So that's why Menopur is a highly purified FSH, LH, HCG combination, and that's why we use it in combination with Follistim and Gonal-F. But the whole process of all these things that the patients had to go, I tell everybody the patients were the pioneers.
Oh, okay.
They were the brave people. They were. Uh-huh. They had to tolerate everything that we were trying to figure out and everything that they went through. And we finally started recognizing that emotional impact, not only the infertility term, an infertile woman, mm-hmm. But an infertile couple, the stress of that alone was overwhelming. But then when they were going through these difficult processes like IVF in those days, in the mid-90s, people started looking at, did some studies looking at,
mind-body.
Yeah, mind-body type combinations. And it showed, hey, these people that got psychological support, it was just looking at that first. Parallel trials and say, yes, they did better. Whether the pregnancy rate was affected initially, statistically or not, the outcome was better. And then they did more studies. And then the acupuncture studies came in, and then the herbal acupuncture combinations. And, you can look at the literature. It's a mixed batch, but there are patients that definitely need it. Mm-hmm. Everybody can benefit, but there are patients that definitely need it. And that profile patient is that I've always encouraged patients to bring that combination in. And that's why you're where you are, and you've done so well with your seed program and everything else that you do. We cannot take care of that whole body as an IVF doctor.
Any more than I could do a pap smear or a transfer. Right. The two are really, they work well together. I
say it's symbiotic.
I
think
agree.
It's a very symbiotic relationship.
It wasn't always, though. I mean, I came on the scene in 2001, and Dr. Dow had been there before, and luckily you and he were friends, and I really wanted to get at that fibroid story you were telling me before the camera started rolling. But the friendship there that you and he formed, let's discuss that. Woman who had those fibroids and...
Well, even before the fibroids.
Okay. Oh, yes, the male.
Dow... I met Dow at a conference, and I think it may have been Pacific Coast, or back then it was called the American Fertility Society, AFS. It had to be at one of those meetings, and he introduced himself, and he said that he was 38th generation doctor of Chinese medicine. And I said, I don't have that kind of lineage. And so we got together and had fun from the beginning. But I knew nothing about traditional Chinese medicine. But I realized where the gaps were in Western medicine and what I was doing. And the more we talked at meetings, whatever, it just made sense to me that this was a big chunk that we were missing as reproductive endocrinologists or doctors in general, not just IVF doctors. And so once I learned a little bit about it, I still tell patients before I stopped practicing, every time I talk to patients about you or anybody that does traditional Chinese medicine, I said, you know what? I wish I knew what they knew, but I don't. And that's why we need those people in your process, because it takes years and years of learning for you to do what you are doing. And the same it took for me. But I wish Western medicine doctors were trained more just with the basics of what you do.
It is a little unbalanced as we have to learn so much Western so that we can be able to communicate with you guys.
Exactly.
Yeah. But I don't know if our patients really understand that, but it is true. We spend 4 years.
They've heard it from me for decades because I really do. I wish I knew everything you all know.
Well, it's a lifestyle thing.
Dow and I got to be friends, and we started because he was very interested in doing some work to show whether TCM in general had could we validate its reality in Western medicine? And I said, yeah. And he said, I said, the one thing that we have a real problem with, this was in the late 80s, I said, we have nothing that we can do for male factor. When the guy comes in with a bad sperm profile, we've got these things and this a long time ago, we had even less any type of natural supplements or anything. We knew nothing about that.
Yeah, no knowledge of antioxidants for the sperm.
No, that the first study for antioxidant in sperm was done in Houston at Baylor, and that was late 90s. And so we were struggling with, and we didn't have ICSI. ICSI didn't come around until 1993, 94. So we were doing all kinds of things with trying to get the sperm into the egg. We kind of opened the zona pellucida and see if they'd swim through, but most of them didn't swim very well anyway. And so we were struggling. So in the late 80s, Dow, I said, Dow, that's our biggest problem. He said, well, we've got herbs that'll help that. And I said, let's do it. So we set up.
Should have been so easy.
We set up a protocol with USC, and we got males to volunteer that were all abnormal semen profiles. And I remember we had a meeting with them, and we told them what we were going to do, and they were going to take these little herbal substances, but it was very important that they stay on the study protocol. And of course, they were all yes, because their wives had pushed them in. Now that we look at it, and their wives said, you get over there. And so we had what we thought was a good energetic group of males. And we started the study, and we had a control group and the treatment group. The control group was a placebo. And we planned the study for about 12 months. And we started, and they had to come in for checks and semen analysis and stuff. And probably about 2 months, 3 months into the study, started noticing the guys weren't showing up for their semen analysis, and then there were fewer and fewer and fewer. And we contacted them, and they had 1,000 excuses. But I got to 6 months, and down I looked at it and said, we've lost our study group and our placebo group. We don't have enough to keep going. And it was just the guys just didn't want to stay on the study. Even their wives were yelling at them. So, we failed on that study, but Dow and I got involved then, and then we started looking at going forward how he could do what he did, and then you guys, he trained so many people that are great like you, and it's just expanded. And I think the IVF centers in the greater Southern California area do understand what you do, and the involvement and the necessity of what you guys do. And there's the people out there who go, oh no, never going to use that. But it's less and less and less. And it's really, to the benefit of the patient. Not just for a baby, because it has a big benefit to that, but them getting through and feeling good and healthy as they're going through this stressful process. IVF is still stressful. No matter how streamlined it's gotten, it's just stressful.
Yeah.
And so...
Well, that I want to talk about. I do want the listeners to hear the story of the woman, your patient with all those fibroids.
Well, this is what blew me away.
Okay.
This is what sealed the deal with me and Dr.
Dr.
Downey. All through my early career, we did surgery for a lot of different things. And one of the things that we usually had no way of correcting other than by surgical treatment was uterine fibroids, uterine leiomyoma. And we had criteria for young women that had fibroids, and fibroids do have a familial pattern. It's on the female genome, and mom that had fibroids or maternal aunt that had fibroids, that daughter has a higher chance of having fibroids. So there is a genetic hereditary pattern to uterine fibroids. And certain races have more risk for fibroids than others. But we had that as a problem. And I'd see young women that were trying to get pregnant. And in those days, we were doing IUIs, and IVF was used only for the most difficult cases. But I had this young woman that came in, had her workup, and the workup included everything that we could do back then, ovulation, hormonal testing that we could do, semen analysis. And we ended with a laparoscopy was required as part of the workup. And when ultrasound became, when we started using vaginal ultrasound, that became a step in the workup of the infertile couple. Abdominal ultrasound was so difficult. You just couldn't get good resolution. So until we could see with vaginal ultrasound, that became a step before laparoscopy. So when we started doing vaginal ultrasound, then we started seeing the uterus, the ovaries, and, totally unlike a cloud pattern with abdominal ultrasound, you could see what you were seeing. So this woman came in, everything was negative except her ultrasound. She had an enlarged uterus. It was when a uterus gets to be an enlarged uterus, it's judged by what a stage of pregnancy would be. So a 12-week size uterus in a non-pregnant woman is a very enlarged uterus, or even larger. But she had 12 to 14-week size uterus because of the large fibroids that she had in her uterine muscle. And I said, wow. I said, these are difficult sized fibroids. And I said, you don't have any other explanation for your lack of pregnancy. We really should talk about surgical removal. And in those days, it required a laparotomy incision, like a C-section incision, to go in and remove each fibroid. And she said, oh, I really don't want to have that kind of surgery. I said, I just don't think that mechanically the fallopian tubes are working because of the mass of the uterus, because the tubes get pulled away when the uterine body gets big, away from the ovaries, and just mechanical egg pickup. That was our belief, and it was real.
And if you were going to do an embryo transfer, the catheter would run into one of those fibroids.
The size of the uterus, right? Well, in those days, the transfers were blind. We didn't have ultrasound use. Right. We didn't start that yet.
I forgot.
So but we felt also with that size uterus, getting pregnant, early miscarriage or second trimester miscarriage was a high risk. And so IVF really wasn't something we would consider. I said, we can see since you've got normal sperm and normal ovulation, we can try a couple of IUI cycles to see, maybe with a little Clomid. And she said, yes, I don't want to do surgery. So we did that, and unsuccessful. And I said, there's just nothing else I can do. I said, but I know that there's a doctor of Chinese medicine that may be able to reduce the size of your fibroids to a less level that we may have some therapeutic choices. And she looked at me like I was crazy. She said, what? I said, no, it's medicine. It's herbal medicine. It's the herbs that they use are where we got our medicines for Western medicine today. I said, they're the natural source of it. We get the chemical combined manufactured source with all the side effects and everything else. And acupuncture is very powerful too. And she goes, oh. I said, well, just think about it. I said, the only thing I can offer you is surgery. She didn't come back after that conversation. I said, okay. I lost a patient because I gave her an alternative that she thinks I'm crazy, whatever. So literally about 8 months later, I find her on my schedule coming in. She started her cycle and she wanted to start getting pregnancy attempts again. I go, okay, I wonder what her fibroid sizes are now. They're going to be huge.
Yeah.
So she's in. I talked to her. I said, well, let's do an ultrasound. And she said, yes, I want to see what my uterus looks like. Didn't tell me anything. And so I'm doing a vaginal ultrasound, and I'm like checking my machine.
I wonder if
checking
she
what's
had...
going on. I'm going, I looked to see if she had a scar on her abdomen before I said anything else, and she didn't. And then I'm really totally, completely wondering what the hell happened. I said, have you been doing anything the last 6 months, 8 months? She said, yeah. I finally decided to go see Dr. Nee. I said, you've got to be kidding me. I said, I cannot see a single fibroid. I said, your uterine muscle is completely normal. Your uterine size is completely normal. And I said, thank you for going and doing that. And we went on. She got pregnant.
So you said that the herbs that he used were estrogen suppressant, probably.
I'm assuming that's
right.
what he did. I called him. As soon as she left the room, I got on the phone and I said, Dow. I said, it's unbelievable. I told him our size. I said, yeah. I told her I thought she was okay now. I said, she's not only okay, I can't see a single fibroid in her uterine muscle. Mm-hmm. And he goes, well, that's a good outcome.
Yeah, he's very humble and very, very cavalier about it all. Yeah, it's interesting, these outcomes. It's the combination of the patient's willingness, right? She had to trust you, and then she had to go and meet him, be poked with needles, take home bags of stuff that looks like potpourri, and then smell up her house and cook it, because I'm sure it was raw herbs at the time, and the commitment that she had to make, right? But that is under the umbrella of patient empowerment. Yeah. And that's where we have, this is what my doctorate was about, the combination of what science can do as IVF and what the acupuncturists can do with herbal medicine, endorphins, and stress reduction. But it's the patient who, like you said, are the pioneers. They're the glue. They're the people who are building the bridge. They're the ones that are helping us to understand one another, because we are in our own lanes doing our work and so busy, hardly ever anymore do we have a chance to say like, hey, this is happening over here or whatever. Like some of us communicate like you got on the phone with Dow, but it's through our patients coming back and giving the information. Mostly we get the information of the follicle count, what they're working with, their labs, and then we go to the pharmacy, we figure out with our 400 bottles of herbs, like what kind of concoction to make for them. But if they are willing to take it, then we can see these kinds of outcomes happen.
The other thing that has really impressed me even more so with traditional Chinese medicine is what your program does with the seed program. It's that and more. And patients, to me, the ones that I've seen a complete turnaround with are the ones that are so anxious and so stressed that I can barely have them listen to what I'm talking to them about, because they're so...
Would you say upregulated?
Extremely. And nothing I can say to them
penetrates,
can bring them down.
Yeah.
And I'm pretty good at that. But once they've agreed to go into your seed program, they're a totally different person when I see them again.
They may not even ever meet me if they're doing the seed program because it's international now.
Some of them have done it
in different
virtually.
It's in 14 countries around the world that we have reports of women using it now. So it's not that I'm just nice to them or wiping their tears. It's giving them an instruction manual of things that they can do to think differently, to down-regulate their nervous system. So,
and I think I've got so many examples of those patients over my career. And, a lot of them will come in and say, I need something for my depression. I need something for my anxiety. And in the old days, I used to say, okay, well, we can try this medicine, or, need to go see a psychiatrist. And they go, no, I can't. I don't want to go. And I got to the point where I didn't even offer that anymore. And what I started saying was that I can give you a medicine, but it's going to have all kinds of side effects. And yes, your anxiety level may go down, but you're not going to like the side effects in your life of taking that medication. The same with antidepressants. And I've convinced them to look at a more natural approach. And I really do strongly believe that. I will take anything other than a medicine with the side effects if I have a choice. Now, that's just me personally. And so I don't take medicines per se. But if I need some, I've done acupuncture. The herbs.
The
capsules are fine.
Yeah,
the tea
we now have it in little packets of granules, so you can just pour it on your tongue like Pop Rocks. The compliance on that is good. Yeah,
I could do that.
Mm-hmm.
But so, it's the side effects that patients deal with, and even the side effects of our medicines that we have to use, and they're natural FSH and LH products or recombinantly produced. So there's very few side effects, but the effects of stimulation, the high hormone levels, they have to deal with those side effects. And so it's just, every time I mention about using traditional Chinese medicine, some eyebrows go up and I say, that's a natural medication. And most people will then bring their eyebrows down and listen. And because that's what they want, and that's what I want them to have.
Mm-hmm. There are a handful of fertility cases that I'm working with who are taking mood stabilizers. Mm-hmm. And the way that I see that is that it kind of limits them where they can't get too much joy anymore. They can't get excited, but of course they're no longer feeling so depressed and triggered with anxiety. So it's good, but in Chinese medicine, we teach that the uterus is the second heart. So if they can't tap into joy, that's a problem, because we need them to be able to go beyond those ranges and to express the tears. So the way that the Chinese medicine can work, the herbs can just expand this range for them where they feel more balanced, which is such a buzzword, but we know when we are balanced by how we feel when we're out of balance. And so I think our goal as the alternative part of the team is to help them stay as balanced as possible. So
no matter what kind of Western medicine that is used for mood stabilization, anti-anxiety medications, it blunts their ability to react. And that's why they use them, because they don't want the deep depression or the high anxiety, but it's blunting. And what you're trying to do is always going to have a limited effect when those are in combination, I believe.
Yeah. Something that really just really moved me was when we were in the quarantine and I decided I wanted to do a study to see what we were all seeing. This was before the vaccines were rolled out. It was when I called you and I said, I need to get some data points here because I'm going to speak at the symposium. And the title of the topic that I've chosen is The Effect of COVID Stress on Infertility Patients. And you said, I'm really glad that you're doing this. And then I was like, okay, there's my permission and there's the push. I have to do it now, because it felt like something that I needed to bring awareness to, which takes a lot of courage, because even now, nobody really wants to talk about it, but we have learned a lot by what happened there, and it's made the patients potentially more willing to sit in the discomfort of emotional imbalance to right themselves. But remember, I asked you, okay, across this like spectrum, what are you seeing? Are you seeing a smattering of like ovarian cysts, canceled IVF cycles because the egg count is low, uterine lining not proliferating, or miscarriage of normal embryos? And you led by saying, first, I just have to say that this patient population, before any of this started, they are so fragile to begin with.
Right.
Do you remember that conversation?
Yeah.
And then you said, yes, to seeing some of that, like what's happening, but for certain, these normal embryo pregnancies being lost.
Yeah, it was horrifying when we started seeing that.
Mm-hmm. And those were women who hadn't had vaccinations and they hadn't had infections. It was purely the stress affecting their hormones. Would you like to throw some medical terms and science at that?
Because I don't think we've really truly understood that process, and I think some of it, I mean, the stress was tremendous. It wasn't just their own personal stress. We were having to shut down our IVF lab. We had to shut down doing embryo transfers for the first 3 months once the lockdown started. And we voluntarily did that. We didn't know what would happen if a woman got COVID after we did an embryo transfer. We didn't know whether the baby fetus was going to be affected. We knew nothing at the very beginning of that lockdown period. We and the American Society of Reproductive Medicine voluntarily put out a statement saying we would want all IVF centers to stop doing transfers after the lockdown. Mm-hmm. And there were some centers that
indefinitely locked them
they
down.
didn't give us a time point.
Mm-hmm.
And we felt strongly enough that that was something we had to do for the protection of the patient and the fetus. Some centers said, nonsense, I'm not going to follow it. They kept working through it. Those centers were highly ostracized by the rest of the network of IVF in the United States, but they just said no. But we felt very concerned about it. We did it. Now that created even more stress for the patients, mm-hmm. if you can imagine. Because a lot of patients said, I'm not worried about COVID. I want to do my transfer. Why are you not doing my transfer? I said, we've decided to follow the voluntary shutdown for your health, your baby's, potential baby's health. So that was more stress they were dealing with, not just worrying about getting COVID. And then when we opened up again, after 3 months plus, we started doing, then they came in, should I do a transfer? What if I get COVID? What if, and so there was just layers and layers of stress and anxiety that the COVID situation had. And that level of anxiety throws this off.
The pituitary.
The
hypothalamus.
The whole neuroendocrine balance that relates to mood, anxiety levels, stress, that changes everything in their hemopoietic system, for that matter. The whole system was in an emergency mode. A lot of adrenaline coming from the adrenals. We still don't have an idea of what that was doing, but we know that it had to be all related to that. Why were these normal pregnancies being lost? They didn't have COVID, mm-hmm. but they were still losing pregnancies. Mm-hmm. Our miscarriage rate, when we started transferring again, because everybody was still concerned about getting sick. Mm-hmm. They didn't want to go outside. So that whole system just completely invaded the balance, the physiologic balance of the woman.
It really showed what I had been teaching in the SEED program, was that stresses, whether it's like the cost of IVF or the cost of your rent or the perceived brokenness or threat because your sister-in-law is conceived before you, like those former stresses were like tigers chasing after you. So then enter COVID, a truly life-threatening pandemic level virus contagion, and truly survival was threatened. But in both cases, I think the mechanism is like when the hypothalamus and the pituitary communicate that it's dangerous, survival's threatened, then it tanks the estrogen levels, and estrogen needs to be up high to stimulate the eggs and get a successful outcome and to sustain a pregnancy.
Yeah, the worst, when we started IVF up again after that shutdown, stimulations, we talked about that. Yeah, the stimulation seemed sometimes normally responding patients, ended up with a single follicle. They didn't get a normal response. Mm-hmm. And we looked at all of that data for over 12 months after we started up again, and it was different. Mm-hmm. And it wasn't just us.
Right.
Most of the IVF centers were struggling with the same things. And I think to me, it was even more of an eye-opening event to say what the brain was doing for and against us. And when the brain is totally out of control and out of balance, the rest of the system follows. And we've always believed that, but I think that COVID event was true evidence of that.
Yeah, well, I think undeniable evidence of that. We now really understand how important it is to keep our stress level managed and in perspective somehow. And in this particular patient population, it's so true.
Well, this particular population is so dependent on the hypothalamic pituitary health before ovarian and testicular health is balanced. And when this goes bad, it's an effect, a cascading effect. There's no doubt in my mind. I've seen it for 50 years. Mm-hmm. And, some people have more of an impact than others. There's no question about it. Some people are more susceptible. Some people are less. I had patients during COVID that, even when we told them they couldn't start, they'd come in and argue about the fact, I want to do it. You have to treat me. Mm-hmm. And I say, no, I don't have to treat you.
Which is
and you need to let this pass so you can be safe when you get pregnant. When we think it's safer to be pregnant, it's not going to be safe until this is gone and we have a vaccine to everybody's. So that conversation was difficult all the time. Some patients just said, I don't believe in it. I'm not going to take the vaccine when it comes out anyway. I said, that's your choice. Mm-hmm. Me being your treating physician during this is my choice. Mm-hmm. And
that was so divisive. And then the conversation of, if you're even talking about it, you can lose your medical license. So then we had that stress on top of the mask wearing and everything. And so it's still like, is it safe to talk about it? I think it's important to talk about it. Yeah. I think it helps us more quickly get back to some perceived normal, right?
Yes.
Thank you for talking to me about it.
Well, it's still got lingering effects, I think. And, I'm worried about all those people and patients that got COVID and had a significant effect or impact from it, a significant level of COVID infection with illness, prolonged illness. And then what's still happening to their system now? We're not going to know that for another 5 or 10 years, I'm afraid, because this virus is nothing we've ever seen before. And I'm no viral expert, but I read everything that was out there when this was happening to try to understand what it was. And today you don't hear much about it, but there's a lot of this long COVID discussion. And, what is it going to really impact? But, that time will tell.
Mm-hmm. Well, and curious minds still waking up at 3 a.m. with ideas. Particularly what I decided to do was I saw it as stickier blood and inflammation. Those were pieces from Western science that we saw, blood clots. Yep. Also, some of my patients, they were doing egg retrieval and pulmonary embolisms. I had never seen that before. So I started making a connection to the estrogen as sticky and these blood clots and endometriosis patients having stickier blood.
Yep.
So across the board, I gave my patients a supplement called serapeptase, which is an enzyme that works on the lungs and blood clots. It's used in endometriosis patients for degrading blood clots and adhesions. So it's not, I don't know, I've never done a study to see if it's going to actually, like Dow removed those, he got the fibroids to go away, but what I saw may have just been anecdotal, but a group of my patients, I think there were like 15 of them, and I gave them all just a small amount of serapeptase, some K2, which was like removing plaques from the small arteries, and then keeping them on fish oil. So thinning the blood, removing the plaques, and addressing potential microclots in the tiny blood vessels. And suddenly, all of my patients got pregnant.
But that makes sense because the one thing nobody understood was what were those inflammatory effects from that viral disorder, or maybe even the vaccines, who knows? But, it was a huge inflammatory, vascular inflammatory effect from the virus itself. I think a lot of people had COVID that didn't know it. I could have been one of them.
They could have been exposed to the antibodies and not testing positive.
Right.
Or just not testing.
Well, even with testing, the tests were not that 50-50 chance that it was real. And so I think a lot of us had it and didn't even know it, but didn't get a severe disorder or disease from us.
Well, that's how it is on the little capillaries. We're not going to feel it like we would feel it if we had a major artery occlusion. But
those tiny capillaries in early pregnancy or implantation or anything
around
else,
the ovaries,
those are the ones that I worry about.
The ischemia,
all the time.
Right? They block the oxygen flow to the eggs. So thank you for validating that it made sense. There's hardly anybody around that wants to talk about it, but my patients are saying, I'll try anything at this point to get my egg counts to come up or to prevent having another loss. And I don't have to tell you, the way that the science and IVF getting here was because you all kept taking chances and trying things out, and the patients were willing, and they were the pioneers.
Exactly. And you have to do that in your field, my field, and that's the only way we can progress and improve. There's 10 years from now, people are going to tell us exactly what you and I have talked about, what was real and what we were off on. But I certainly think that your direction is what we're seeing. So, there's still so much. The other area that always I struggled with was ovarian response, follicular development, follicular sensitivity, follicle growth. And I've worked with so many of you folks and seen the benefit, and it's not just the fact that they are becoming more balanced emotionally. They're getting an effect from the herbal medicines that they're taking and the acupuncture. Strongly believe. Patients say, well, I've done acupuncture. I said, no, you have to do both. That was my belief. Whether that's true or not, I said, you've got to have somebody that'll use a combination if it's necessary. And I said, especially for ovarian responsiveness, that's usually the approach, but they're going to decide whoever you see. But that was, the most difficult area. And as you know, we've worked with patients that, are just, their ovaries are just dwindling. And yes, there's a biologic reason for that. They were born with all the eggs in their ovaries they have for their lifetime at the time they were born. And at puberty, they start with that set number of eggs. And that egg allocation program starts with menarche. And when menopause occurs, it occurs because they're out of follicles. They have nothing left to make estrogen. So their eggs were used. How they allocate them over that 40, 50-year time period, we have no control of it until we do an ultrasound and look at what their follicle numbers are supposed to be and where does it relate to their age group. But I have been pleasantly seen the benefits of, we can use estrogen, we can do things trying to sensitize the follicles, but I've always gotten to the point of saying, you know what, we're not helping with our Western medicines or hormones, and you got to have something that goes down to the base of this problem more than we can. And not every patient improves, but obviously there's a good percentage that do with that approach that you folks take. And those are a difficult group because, they need to get pregnant and their egg number is just usually not there, and their age is part of the problem most of the time.
Right. So the pilot study that I did it was only 10 women case studies, but they were poor responders, advanced maternal age, low AMH, high FSH, male factor was not an issue. Yeah. And they had historically just done IVF like recently. So we had that historical data. And you sent one in to the study who was, and they were already doing acupuncture, all of them, but it wasn't quite enough.
Right.
So, and presumably they were using herbs, but the mindset thing had to be clicked into place because the acupuncture is great for eliciting endorphins and moving the energy through the channels that go through the ovaries. But in these cases, they never met me, these 10 women. But when I analyzed the data later, it was fascinating because they all did an entrance survey about what do you think will happen if you use an online program to improve your egg count. And your patient who had asynchrony, so really she shouldn't have even been in the study because she wasn't having a poor egg count. It was asynchronistic type of scenario. But she said, no, I don't think that an online program will make any difference. So we tracked her and she spent 20 minutes total and she had no change. Eggs were still asynchronous, and that was that. So then we had these other 9. Of those 9, there were 33 mature eggs collected by these women. After the seed program intervention, they had 58 mature eggs retrieved. Before the intervention, collectively, there was 1 normal embryo. Tested blastocyst. Then they did the intervention. There were 3 normals. So that was great. Those 3 were transferred in and 3 live births resulted. But 2 other women, as I've looked back over this now, 2 other women decided to go into egg donation. And now they have, one of them has 1 kid, the other one has 2 kids. So of those 9 women, 6 babies born.
Yeah.
So it was, and it all happened pretty quickly and they never met me. So it was like they made the decision. Science and their doctors had this offering and, the rest is history. And for those women who became moms, they're forever changed by these ideas that we decide to float out there.
All right.
So I feel like this is probably a good place to stop unless you have anything you want to add. Now you are retired from patient care. You are the medical director of Pinnacle Fertility. I'm not sure what that looks like now for you. What are you doing these
well,
days?
I'm supposed to be retired, but I'm still working a lot. But it's a good step down for me. I mean, for 42 years, I was running 100 miles an hour.
Yeah.
And then the end of December of 23, they said, okay, stop.
Right.
Well, that's not me. So the medical director we've got 11 different centers in the Pinnacle network and all around the United States. And I'm enjoying working with all of those doctors. I'm enjoying working with all the lab people. I have a laboratory leadership group and a medical leadership board, and I make them work together. So many
That's what
IVF
you do.
centers don't. The doctors do their thing, the lab people do their thing, and when there's a problem, they start arguing with each other. Why is that? And I said from the very beginning that we have to work side by side. I'm not going to talk to one group without the other group. There's so much that we do as physicians, stimulating patients, and the egg going into the laboratory and the egg doesn't look good, we blame the lab. But we really need to start taking some responsibility for that. And that was the first big hurdle, because everybody's got their egos, but we now, after this year's full-time with this, I worked as the part-time director because I was doing clinical practice. We really got a lot of things done the first 2 years before I retired, but it's a lot of fun now because everybody's talking, everybody's listening. When there's a problem, everybody figures out how to solve it. If there's a problem in the lab, we recognize it. We don't point fingers. We say, okay, this is what's done in this lab, and it's working better for them, so see if that helps your situation. And everybody, it's like the 5 centers in 1980 as we were starting. It's a lot of fun because it's looking at data, making decisions to improve patient care, and that's what everybody wants to do. So I'm enjoying it.
I love to see you get this full circle moment in your career. And I would imagine that in being out of patient care, you probably miss the women, but you have more energy and you've got a different level of enthusiasm to go back to how it started in the first place.
Yeah, I really enjoyed the 10 years that I taught at USC, and I missed it when I left academic medicine. And so this is bringing me back to that because to me, I just think we've got a group of doctors that are all in one university doing the same thing and trying to make things better. And so I'm really privileged to be able to do that.
Mm-hmm. Yeah, well, you earned it. And I don't care what you say. I definitely see you as the pioneer. So thank you for your contribution to science, to fertility, to women the world over and couples that you've helped. I'm going to thank you from them. But
I want to thank you for the things that you've looked at, your inquisitive nature and your approach to ask and answer questions and make some decisions is, I wish everybody on both sides of this field, whether you're talking about traditional Chinese medicine or reproductive endocrine infertility groups, we all still have to be doing that. And I tell them every day that we've got to ask questions or we can't progress from where we are. And so I compliment you for doing that.